Welcome to the Deep Dive, your source for turning complex professional material into actionable, well-structured knowledge designed to give you a serious head start.
Hello.
Today, we are undertaking a really extensive deep dive into the very foundation of professional nursing practice.
That's right.
We're talking about the core concepts that really launch a student into the world of contemporary medical surgical nursing.
And our mission today is to, act as your expert guides. We're going to extract the most important insights from this foundational textbook chapter.
So, a structured shortcut, basically.
Exactly. We're here to give you a definitive structure, guiding you step by step through things like the core mechanisms of clinical decision-making, quality assurance mandates like QSEN and EBP.
And the 5 meticulous steps of the nursing process.
Right. And we'll also get into the complexities of ethical care, which is a huge topic.
So this whole deep dive is designed to be that shortcut. We're going to define the landscape, what nursing truly is, how things like demographics and technology are reshaping healthcare.
What the quality standards demand of you.
Yes. And the critical cognitive skills you have to master, and then how to execute that nursing process in a really systematic way.
Think of this information as like the professional operating system you load before you start running the clinical applications.
That's a great way to put it.
Because if you understand this structure, you can prioritize, you can plan, and you can deliver safer, more effective care for every single patient, no matter what their medical diagnosis is.
So our journey starts by solidifying the language we use, the fundamental definitions that really anchor the profession.
Let's do it.
Okay, section 1, core concepts and definitions.
So when we talk about nursing, we really have to move beyond the sort of lay definition.
Right.
The American Nurses Association, the ANA, they provided a really seminal definition back in 2015 that dramatically expanded the scope.
Okay, so let's unpack this official ANA definition. It's not just about, treating the sick.
Not at all.
It covers the protection, promotion, and optimization of health and abilities, prevention of illness and injury, facilitation of healing, alleviation of suffering through the diagnosis and treatment of human response and advocacy.
And that phrase, diagnosis and treatment of human response, that is so crucial.
Why that part specifically?
Because it's what differentiates nursing from medicine. See, medicine diagnoses and treats disease.
Okay.
Nursing diagnoses and treats the patient's response to that disease or to an injury or even to a potential problem. The nurse is really positioned as the central advocate, focusing on those holistic outcomes.
And it goes beyond just the clinical bedside role, right? I know the International Council of Nurses, the ICN, also stresses a much broader professional responsibility.
Absolutely. The ICN highlights nursing roles that extend way out into public health and policy.
So things like?
Things like promoting a safe environment, engaging in research to advance the practice, participating in education for patients, for colleagues.
And even shaping health policy.
And critically, yes, actively shaping health policy. This really confirms that nursing is a policy-making, research-driven profession. It's not just a procedural one.
Okay, so that sets the scope. Now let's address the semantics of the relationship. Are we talking about a patient or a client?
This is a fascinating linguistic and professional debate.
I've heard it go both ways.
Right. So the term patient comes from a Latin root meaning to suffer or to endure. It historically implied a kind of dependence.
I see.
On the other hand, client comes from a Latin verb meaning to lean upon, which suggests more of an alliance or interdependence.
So client sounds more collaborative.
It does. And a lot of nurses and academics prefer client for that exact reason. But, and this is important, you'll find that the source material and the vast majority of practicing clinicians still predominantly use the term patient.
So why do clinicians stick with patient if client has that better, more collaborative feel?
It's mostly due to standardization in the institutional setting. Organizations like the Interprofessional Education Collaborative, or IPEC, which guides standards across all health professions.
They use patient?
They use patient. So for a nursing student, the takeaway is to recognize that while your attitude must always be collaborative, treating the person as a partner, the term patient is still the industry standard.
That makes sense. It sets the professional relationship. Now let's tackle the ultimate goal, the state of being we're aiming for, defined as health and wellness.
Okay, so we start with the World Health Organization, the WHO. Their definition from 2006 says, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity.
Complete That sounds like a very high bar. The text even suggests it might be a bit too idealized for the real world.
That's exactly the critique. The source material labels it too utopian.
Right.
If health requires complete well-being, then most people, especially anyone with a chronic illness or a disability, would.
Yeah.
Well, they'd never achieve it.
So that critique allows us to define wellness as something different.
Precisely. It lets us define wellness as a separate, more attainable, and proactive goal.
So wellness becomes the achievable objective, even if complete health, by that WHO standard, is out of reach for a lot of people.
Exactly. Wellness is defined as proactive self-care activities that are directed toward achieving higher levels of well-being. It's a continuum.
And the nurse's job is to maximize the patient's position on that continuum.
Yes. The source breaks wellness down into 4 essential components.
Okay, let's detail those components since they define what nurses should be trying to measure.
First, wellness involves the capacity to perform to the best of one's ability.
Okay.
Second, it's the ability to adjust and adapt to different life and health situations.
Mhm.
Third, a reported feeling of well-being by the individual themselves.
And the 4.
And fourth, that kind of holistic feeling that everything is together and harmonious. So when a nurse focuses on wellness, they're aiming for positive changes across all those domains.
Supporting the person's highest possible functional level, even if they still have a disease.
You got it.
Okay, moving from these general definitions to prioritization. I mean, Maslow's hierarchy of needs is arguably the most critical framework for organizing clinical thought.
It is the cognitive template for prioritization.
Mhm.
It really is. Maslow's hierarchy, which you often see as a pyramid,
Right, figure 1-1 in the textbook.
it provides this crucial structure for nurses to prioritize a patient's problems, their strengths, and then the interventions that follow. The basic principle is that lower-level needs have to be met before you can even think about pursuing higher-level needs.
Let's walk through those 5 levels, starting at the bottom with the most immediate life-sustaining needs.
Right at the base are the physiologic needs. We're talking oxygenation, nutrition, elimination, sleep, water, temperature regulation. If a patient isn't breathing,
Nothing else matters.
nothing else matters. Once those are stable, the patient moves up to safety and security needs. That's physical safety, sue freedom from injury or infection, and also financial security.
After safety, the needs start to become more psychological and emotional.
They do. The next level is a sense of belonging and affection. This speaks to relationships, the need to feel accepted. Above that, esteem and self-respect, which is about achievement, competence, independence, and getting recognition. And then at the very peak of the pyramid is self-actualization.
And that includes self-fulfillment, the desire to know and understand.
And even aesthetic needs. It's about reaching your full potential.
So let's make this practical. When a nurse walks into a patient's room, how does this hierarchy translate into a real decision?
Okay, quick scenario. You have a patient who just had surgery. They're complaining of 8 out of 10 pain. You also know they need discharge education on managing their diabetes. What do you do first?
The pain.
Why?
Because it's a physiologic need. It affects sleep, mobility, even oxygen demand. The education part is a higher level need.
Exactly. The education falls into that desire to know and understand category of self-actualization. So Maslow's gives you the immediate justification for your clinical triage. It's not just a gut feeling, it's a framework.
That structural guidance leads right into the idea of health promotion.
Health promotion is really the application of all these concepts. It moves beyond just treating the illness you see in front of you and focuses on the potential for wellness.
So you're targeting intentional changes in habits, lifestyle, environment.
All to reduce risks and enhance well-being. It's about empowering the patient to adopt healthier practices for themselves.
And you can't really talk about health promotion today without acknowledging the massive impact of technology.
Oh, absolutely. The source material specifically highlights mobile technologies. I mean, think of everything from a Fitbit tracking your steps to specialized apps like Carb Manager for your diet, or even apps designed to help with medication adherence.
The advantage there is the tailoring, the personalization.
It's all about tailoring. These advances let nurses and patients personalize and monitor health promotion activities based on specific individual data. And the research shows it positively affects diet, physical activity, medication adherence, and health knowledge.
And the delivery system that supports this whole proactive model is primary healthcare.
Primary healthcare is absolutely foundational to all of this. Its role is to make sure people get comprehensive care, everything from promotion and prevention to treatment, rehab, and palliative care, as close as possible to their everyday environment.
So it's community-based.
It is, and it stresses empowerment, public participation, and paying attention to societal needs for healthcare through social policy action. It's the mechanism for making wellness promotion accessible and effective for everyone.
Okay, so we've established the core definitions and that key prioritization framework. Now we need to pivot to the environment, the demographic and technological forces that are dictating how and where nurses practice today.
Right. And these shifting demographics represent just monumental challenges and, opportunities for the healthcare system,
And the most pressing trend has to be the aging population.
without a doubt. In 2017, there were 47.8 million Americans aged 65 and older, and that number is it's growing rapidly.
And globally, this trend is even more dramatic. It's forcing a massive reorganization of resources.
It is. The number of people 80 or older worldwide is projected to increase more than threefold between 2017 and 2050.
Wow.
We're talking about a surge from 137 million to 425 million people in that age group alone. This requires huge professional investment in gerontologic specialists, in technology, and in financial resources.
So what are the specific clinical implications of this aging population for a medical surgical nurse on the floor?
The critical implication is complexity. So many older adults suffer from multiple chronic conditions or comorbidities, which makes their care plans incredibly intricate.
And the source also points out something specific about older women.
Yes, it highlights that older women are frequently underdiagnosed and undertreated. This means nurses have to apply a really skeptical and comprehensive assessment approach. You can't just attribute every complaint to old age.
Okay, next, the increasing cultural diversity of the population is completely redefining the professional approach.
It is. By around 2044, non-Hispanic Caucasians are projected to collectively comprise the minority of Americans.
And that change means that patients from diverse sociocultural groups are bringing unique health beliefs, different values.
Varying risk factors, and even different reactions to treatment and pain.
So the big takeaway here is that a one-size-fits-all standardized care plan is probably going to fail if you ignore those cultural factors.
It is. If nurses fail to assess, understand, and respectfully integrate these diverse characteristics, the care you deliver might not just be ineffective, it could actually violate the patient's autonomy. Effective care in the 21st century absolutely requires rigorous cultural assessment and humility.
We also have to address the socioeconomic realities like the increase in homelessness and poverty.
The source notes a really concerning increase in homelessness. It was up 3% between 2018 and 2019, and it has a disproportionate impact on minority populations.
And this population faces huge barriers.
Huge barriers to accessing preventative care, adhering to treatment, and meeting basic needs like nutrition and safety. Nurses often see these individuals in the emergency or acute care setting, and the challenge is bridging that gap between the acute treatment we can provide and the lack of community support systems they face when they leave.
And finally, there's a unique and very large group, veterans.
Yes, with 18 million veterans, including 1.8 million women, this population really needs tailored care. Their service often results in distinct health challenges.
Like what?
High rates of substance use disorders or SUDs, post-traumatic stress disorder, PTSD, traumatic brain injury, TBI, and an elevated risk for suicide and depression. Plus, they might present with service-related conditions like exposure to hazardous substances or amputations. The nurse has to recognize and specifically screen for these issues when taking a veteran's history.
Okay, so as the population changes, the dominant patterns of illness are changing too.
They are. Chronic diseases now account for 7 out of the 10 leading causes of death. This is a fundamental shift from a century ago when acute infectious diseases were the main threat.
So the goal is no longer just cure or eradication.
No, not at
Yeah.
all. Healthcare has had to drastically broaden its focus. The emphasis is now on health promotion, managing comorbidities, preventing complications, and managing those flare-ups or exacerbations of chronic conditions like heart disease, diabetes, and COPD.
And this preventative focus is actually codified in major public health initiatives.
That is.
Which brings us to Healthy People 2030. What's its core vision?
The vision of Healthy People 2030 is to optimize health and well-being for all people in the U.S. across the entire lifespan. It explicitly continues the focus on reducing health disparities, improving health equity,
And addressing the social determinants of health.
and seriously addressing the social determinants of health. Things like poverty, access to transportation, education, safe housing. These conditions profoundly shape health outcomes, and nurses need to assess them just as rigorously as they assess vital signs.
Moving to the technological influences, how is something like the Precision Medicine Initiative, or PMI, changing the individual plan of care?
Precision medicine is a really exciting evolution. It leverages advances in research, technology, and policy to develop highly individualized plans of care.
How is that possible?
It's possible because of the vast biologic databases we have now, like human genome sequencing and computer-driven systems that can analyze massive data sets to find unique genetic or biological markers.
So it's moving away from a one-size-fits-all approach.
Exactly. While it started with a focus on cancers, the PMI promises to redefine treatment for countless conditions.
That reliance on massive data means that health informatics, or HIT, is now a core professional competency.
Oh, absolutely. Health informatics is an interdisciplinary field that uses technology to improve the quality, efficiency, or delivery of care. And the source mentions recent advances like artificial intelligence, blockchain, cloud technology.
And crucially, improved interoperability of electronic health records, or EHRs.
Yes.
So for a practicing nurse, what does it mean to engage with something like AI or blockchain?
Well, for AI, it means interacting with systems that might give you decision support or flag potential risks based on pattern analysis from millions of prior patients. Blockchain is a decentralized ledger system, and it significantly improves the security and integrity of the EHR.
So make sure patient data is secure.
Right, that it's securely transferred and can't be tampered with. And nurses need to understand that systems like the Tiger Initiative are actively working to integrate these HIT competencies into nursing education, so they can effectively use things like the ICD-10 coding systems, which are necessary for tracking disease prevalence and facilitating reimbursement.
And outside the hospital, technology is delivering care through telehealth.
Telehealth uses technology to deliver healthcare, information, or education at a distance. And nurses use two main applications.
What are they?
There's real-time communication, which might be a nurse practitioner having a webcam consult with a specialist who's miles away.
Okay.
And then there's store and forward. This involves transmitting digital images or medical records for a specialist to review later. It's really common in dermatology or radiology.
And telehealth is really expanding home health services.
Dramatically. And it's reaching patients in rural or underserved areas, which requires nurses to develop new skill sets in remote monitoring.
Okay, we've set the stage with demographics and technology. Now let's move into the bedrock of modern nursing, the professional mandate to ensure quality and safety.
And this mandate was really driven by two shocking and seminal reports from the Institute of Medicine, or IOM, right at the turn of the century.
Right. The first was in 2000, To Err is Human.
And that report was a bombshell. It revealed that nearly 100,000 Americans were dying annually from preventable hospital errors. It just fundamentally challenged the assumption that the healthcare system was inherently safe.
That revelation was followed by Crossing the Quality Chasm in 2001, which identified the systemic failures.
It did. That second report described a system that was fragmented, inefficient, and often inequitable. And to address these systemic issues, the IOM proposed 6 key aims for improvement that define quality care today.
And those 6 aims for all patient care are what?
Care must be safe, so avoiding injuries. Effective, providing services based on scientific knowledge. Patient-centered, respecting and responding to patient preferences.
And then timely, efficient, and equitable.
Right. Timely to reduce harmful delays, efficient to avoid waste, and equitable, meaning care that doesn't vary in quality based on personal characteristics. These are the metrics by which hospitals and nurses are judged today.
So how do nurses actually operationalize these aims? It's through evidence-based practice, or EBP.
EBP is the engine of quality improvement. It's defined as a best practice that's derived from valid and reliable research studies. But, and here's the critical distinction, EBP is not just research.
What else is involved?
It requires the integration of 4 components: the best research evidence, the specific clinical healthcare setting, the patient's own preferences and values, and the nurse's clinical judgment. If you skip any of those, you aren't practicing true EBP.
I think EBP bundles are the perfect example of making EBP practical and measurable.
They really are. They showcase the huge results that simple interventions can achieve. The Institute for Healthcare Improvement, the IHI, popularized these bundles, which are sets of 3 to 5 highly evidence-based practices that, when implemented reliably together, measurably and dramatically improve outcomes.
Can you elaborate on the IHI ventilator bundle example? Why is that one so effective?
It's so powerful because it relies entirely on simple, diligent nursing actions to prevent a really deadly complication: ventilator-associated pneumonia, or VAP.
So what's in the bundle?
The bundle requires nurses to make sure the head of the patient's bed is elevated 30 to 45 degrees, to provide meticulous oral care using chlorhexidine, and often to include daily sedation interruptions. By consistently doing these 3 simple low-cost steps, VAP rates just plummeted globally. The insight here is that consistent adherence to basic EBP is the key to massive quality improvement.
And outside of bundles, what other EBP tools are there to guide the care planning process?
Well, nurses use clinical guidelines, which are standardized protocols for specific conditions. We also use algorithms, which are like decision-making trees, often for acute situations.
Okay.
For longer-term planning, there's care mapping and multidisciplinary action plans, or MAPs, which are often used interchangeably with clinical pathways.
And these map out the expected course of treatment.
Exactly, for a specific duration, like 3 days after a heart attack. And they help coordinate the efforts of every single member of the interprofessional team.
So if EBP tells us what works, then QSEN tells us how the nurse needs to be trained to implement it.
That's a perfect way to put it. The Quality and Safety Education for Nurses Project, QSEN, it arose directly from those IOM reports. And its goal is rigorous: to prepare future nurses with the specific knowledge, skills, and attitudes.
The KSA model.
Right, the KSAE model required to continuously improve the quality and safety of the healthcare systems where they work.
And this KSA model demands competence in 6 core areas. Let's list them.
Okay, they are patient-centered care, teamwork and collaboration, EBP, quality improvement, safety, and informatics. A nurse is professionally incomplete if they only master 1 or 2 of these. You have to function across all 6 domains at the same time.
To really drive home how specific the KSA model is, let's look closer at one of those domains, teamwork and collaboration, as it's detailed in the Sources Table 1.1.
This detail is so critical for students to grasp. When it comes to teamwork and collaboration, the nurse's knowledge has to include understanding the roles, the scopes of practice, and the values of other health team members.
Okay, that's the knowledge piece. What about the skills?
The skills component requires the nurse to demonstrate awareness of their own strengths and limitations, and to willingly assume the role of team member or leader, depending on the situation, and to be skilled at respectfully initiating requests for help.
And then there's the attitude component, which is probably the hardest to measure but might be the most vital for effective collaboration.
It is. The required attitudes include valuing the perspectives and expertise of all health team members, regardless of their place in the hierarchy, and respecting the centrality of the patient and family as core, non-negotiable members of the healthcare team. QSEN sets this high bar because open communication and shared decision-making are impossible without that attitude of mutual respect.
So, building on QSEN's mandate for teamwork, we can zoom out to the broader system framework, Interprofessional Collaborative Practice, or IPEC.
IPEC mandates that multiple health professionals, nurses, physicians, pharmacists, dietitians, social workers, all have to work together with patients, families, and communities to deliver best practices. And this collaboration is directly linked to better patient outcomes and safer care.
The IPEC framework organizes its competencies into 4 core domains.
Correct. As you can see in Figure 1-2. These domains are all nested under the main concept of interprofessional collaboration.
And they are.
They are values ethics for interprofessional practice, so working with mutual respect, roles and responsibilities for collaborative practice, so understanding your scope and the limits of others, interprofessional communication practices, using standardized, clear language, and finally, interprofessional teamwork and team-based practice, which is all about shared decision-making.
Why is standardizing the language so important in this framework?
It addresses a massive historical flaw in healthcare. I mean, if a nurse, a physician, and a physical therapist are all using different words to describe the same patient condition or the same goal, communication just breaks down.
And that leads to errors.
It leads to errors. The IPEC domains prioritize standardizing language to improve that flow of communication, which is crucial as we shift more focus toward managing population health. The shared vision is that this standardized, collaborative approach is the only way to meet those IOM aims for safe, high-quality, patient-centered care.
Okay, we've established the standards and the team. Now we have to focus on the cognitive engine that processes all this information. Critical thinking. This is the skill that separates a technically competent nurse from a truly professional one.
It really is. Critical thinking is defined as a cognitive process that is purposeful, insightful, reflective, and goal-directed. It's based on a structured body of knowledge, and critically, it includes reasoning and judgment.
So it's the ability not just to see the data, but to question the data.
And to question your own processing of it.
So how does a nurse make sure they're constantly questioning and refining their own thought process?
Through metacognition. Metacognition is the examination of one's own reasoning or thought processes. It is literally thinking about your thinking. This constant self-reflection is absolutely key to refining those skills, and it lets the nurse spot faulty assumptions or inadequate data early on.
And how does that relate to clinical action?
Well, critical thinking leads to clinical reasoning, which is the specific thought process you use to analyze patient data. This reasoning then culminates in a clinical judgment, which translates directly into the nursing actions you take at the bedside. Critical thinking is the systematic process. Clinical judgment is the actionable output.
What are the core skills that define a master critical thinker in a clinical setting?
The list includes interpretation, analysis, inference, explanation, evaluation, self-reflection, and self-regulation. A critical thinker doesn't just treat the symptom. They validate the accuracy of the data. They evaluate the reliability of their sources, like, is the patient's report reliable? Is the lab result consistent with the physical exam?
So they question inconsistencies.
They question inconsistencies, and they use logical thinking to systematically justify every action they take.
The text mentions intellectual integrity as being vital to critical thinking. Why is attitude so important here?
It's crucial because as human beings, we all carry inherent biases. Critical thinkers have to be inquisitive truth seekers, they have to be open to alternatives, and they have to possess the courage to question their own ethical framework. They have to persevere to constantly minimize the effects of personal bias.
Like egocentricity or ethnocentricity.
Exactly. Egocentricity, seeing things only from your own perspective, or ethnocentricity, believing your own culture is superior. If you let bias corrupt your data analysis, you just cannot achieve an accurate clinical judgment.
Afaro Lefebvre provided a detailed roadmap of the key mental activities that high-level critical thinkers perform in practice. This makes the abstract concept really practical.
It does. Let's walk through some of them.
So detailing some of these practical mental activities, starting with the flow of decision-making.
Okay, so they start by identifying priorities, often using Maslow's as a guide. Then they systematically gather and validate all the pertinent data, making sure the evidence is based on valid research. They analyze this information to find clusters or patterns data points that hang together and suggest a specific problem.
And they're using logical, theoretical, and intuitive thinking all at once.
All at once. And when a situation is fluid, maintaining flexibility is non-negotiable.
Right.
They have to use inductive reasoning, moving from specific observations to a general conclusion, and deductive reasoning, moving from a general principle to specific conclusions, to analyze options and formulate creative yet sound decisions.
And they demonstrate personal humility.
Yes, that's key. Willingly seeking information and consultation when they hit a knowledge gap.
And finally, that difficult concept we mentioned, bracketing.
Bracketing is that essential professional act of detaching your personal viewpoints, your assumptions, your biases from the situation to look at it objectively.
So for instance, if you're treating a patient with an addiction whose lifestyle choices you might personally disapprove of,
you have to bracket those personal feelings to provide objective, compassionate, and appropriate care. Bracketing ensures the care plan is based purely on the patient's needs, not the nurse's moral framework.
the text summarizes this constant mental activity in what it calls the inquiring mind.
And this is a powerful illustration. It's chart 1-1. It shows the constant internal flow of questions a nurse has to ask. It's never static.
So the nurse is continually asking things like,
What relevant assessment information do I need, and how do I interpret this in the context of their history? Have I gathered all the necessary objective data, signs, symptoms, labs, emotional factors? What risks are specific to this patient, and what do I have to do to minimize them?
and as the complexity increases,
Questions get deeper. Am I dealing with an ethical issue here, and how am I going to resolve it using a systematic approach?
this systematic approach to thinking naturally translates into the systematic approach to care, the nursing process. This is the deliberate problem-solving roadmap that ensures all patient health needs are met in an organized way.
Right, and the nursing process is an iterative loop. It's made up of 5 interdependent steps: assessment, diagnosis or problems identification planning, which includes identifying outcomes, implementation, and evaluation. We have to dissect each step because this is the functional blueprint for your entire professional career.
Okay, step 1, assessment.
Assessment is the foundation. It's the systematic collection of data, both subjective and objective, through interview, observation, and examination to figure out the patient's current health status and identify any actual or potential problems.
And then the primary method is the health history interview.
Which is the first point of contact and relies so heavily on therapeutic communication. The quality of the information you get is directly correlated with your communication skills. Trust and rapport aren't just nice to have. They're essential clinical tools.
Let's elaborate on some of those key therapeutic communication techniques from Table 1-2, since they're such essential skills.
Okay, consider silence. In a fast-paced environment, silence can feel awkward, but therapeutically, it gives the patient time to think, organize their thoughts, and it promotes insight.
And what about something like restating?
Restating involves summarizing the patient's main thought. This validates that the nurse understands, and it encourages them to elaborate further. Reflection directs the patient's feelings or ideas back to them, helping them recognize and clarify their own emotional state.
And focusing.
And focusing is essential for keeping a conversation, especially with an anxious patient, goal-directed, and moving toward the assessment data you need.
Once all that comprehensive data is collected, proper and secure documentation becomes paramount.
The data has to be recorded in the permanent record, which is now almost exclusively the electronic health record, or EHR. And the EHR serves multiple functions. It's a legal and business record, it's the basis for quality evaluation, and it's data for research. And crucially, the nurse has to strictly adhere to HIPAA requirements, protecting all private health information, or PHI, whether it's verbal, written, or electronic.
And we should reiterate the critical ethical and legal violation regarding translation services here.
Yes. Using family members, friends, or ancillary staff who are not professionally certified interpreters for non-English speakers is a serious breach of confidentiality and HIPAA.
Why is that?
Because the non-professional interpreter may not accurately translate medically complex information, which risks patient safety violating beneficence and non-maleficence, and more technically, they aren't covered by the same confidentiality agreements, which violates the patient's right to PHI security. Certified translation services must be provided by the institution.
Okay, on to step 2. Diagnosis or problems identification. This requires a huge cognitive shift for new professionals, differentiating between a medical diagnosis, which describes the disease, and a nursing diagnosis.
A nursing diagnosis is a formalized clinical judgment about an individual's, family's, or community's actual or potential health problem or promotion state that can be managed by independent nursing interventions. That's the key difference. Independent action. These statements guide the care plan.
Can you provide an actionable example of how a nurse moves from a patient observation, a symptom, to a formalized nursing diagnosis?
Sure. A patient might just say, I feel so tired all the time. That's a symptom. The nurse does a targeted assessment, maybe finds low hemoglobin and iron stores, and notes the patient is highly sedentary. The formalized nursing diagnosis, using a standardized system like ICMP, would be fatigue related to anemia as evidenced by patient report of constant exhaustion and laboratory findings.
So, problem, etiology, evidence.
Exactly. That structured phrasing immediately focuses the independent nursing interventions, like teaching energy conservation techniques or giving diet advice.
Then we have collaborative problems, which are fundamentally different because they require interdependent action.
Right. Collaborative problems are physiologic complications that the nurse has to monitor for to detect their onset or any change in status. Examples would be risk for shock, hemorrhage, or respiratory failure. These require both physician and nurse-prescribed interventions to manage or minimize the complications. The core nursing action here is surveillance, assessment, and rapid communication with the whole team.
So how does a nurse apply the decision algorithm from Figure 1 to 4 to know which type of problem they're dealing with?
It's a clear test of independence. If the nurse can independently manage the problem through assessment, teaching, emotional support, and comfort measures, it's a nursing diagnosis. If, however, the nurse detects a complication that requires medication, surgery, or other interventions that need a physician's order, it becomes a collaborative problem.
And the nurse's role shifts to monitoring.
The primary role becomes proactive monitoring and reporting. Collaborative problems focus on complication surveillance, not on independent goal setting.
Got it. Step 3, planning. This is the crucial step where the course of action is formalized, including prioritization, setting goals, and determining interventions.
And prioritization is often driven by Maslow's hierarchy. The next step is setting goals, immediate, intermediate, and long-term, which have to be realistic and measurable. The goal defines the patient's desired resolution of the problem.
Let's revisit that example of the patient with impaired mobility after a total knee replacement to illustrate the timeframes.
Okay, an immediate goal might be achieved within hours. Patient stands at bedside for 5 minutes, 6 to 12 hours after surgery.
And an intermediate goal.
An intermediate goal might take days. Patient ambulates 15 to 20 minutes with a walker or crutches by discharge. The long-term goal is achieved after hospitalization. Patient ambulates independently 1 to 2 miles each day within 6 weeks. Without those timelines, evaluation is impossible.
Goals then lead to the measurable criteria we call expected outcomes.
And expected outcomes have to be extremely specific and measurable. They define the patient's desired behavior or physiological state. To standardize this measurement, nurses use the Nursing Outcomes Classification, or NOC.
And that's described in Chart 1.3.
Yes. NOC uses a neutral statement coupled with a structured rating scale. For example, you might measure cardiac pump effectiveness on a scale ranging from severe deviation to no deviation from normal. This standardization is critical for research and for comparing across different systems.
And finally, we select the nursing interventions.
These are the actions: individualized, ethical, and culturally appropriate, designed to help the patient achieve those expected outcomes. And here we rely on the Nursing Interventions Classification, or NIC.
Which is in Chart 1 to 4.
Right. NIC provides a standardized, comprehensive taxonomy of independent and collaborative interventions. It helps prevent confusion and promotes evidence-based care.
Can you elaborate on the depth of detail that a single NIC intervention, like fluid resuscitation, provides?
Sure. When a nurse selects a high-level NIC intervention, like fluid resuscitation, the system immediately provides a comprehensive list of specific nursing actions. This might include obtaining large-bore IV access, administering prescribed fluids, continuously monitoring the patient's hemodynamic response like vital signs, CVP, monitoring intake and output, and, critically, monitoring for signs of fluid overload or other complications. NIC moves the nurse beyond just a general concept to specific, structured, evidence-based actions.
Okay, that brings us to step 4, implementation.
Implementation is the action phase. It's the actual execution and carrying out of that formalized plan of care.
And implementation statements are always action-oriented.
Always. They start with a verb, like supervise the patient performing active range of motion exercises or administer sublingual nitroglycerin as prescribed. It's the coordination of all the activities needed to achieve the goals.
A vital professional standard here is interdependent functioning. This is where critical thinking gets applied to the implementation phase itself.
This is professional accountability in action. While nurses administer prescribed treatments, they are never just passive followers of orders. They have to critically assess and question any prescription medication, procedure, treatment from other health team members if it seems unsafe, inappropriate, or inconsistent with the patient's condition.
The nurse is the last line of defense.
They are. And throughout implementation, the nurse is continuously reassessing the patient's response and is ready to revise the plan immediately if the patient's needs change.
The final step, step 5, is evaluation. This is the quality check determining the patient's response and the extent to which the expected outcomes have actually been achieved.
And the evaluation phase has to be rigorous. The nurse uses the documented outcomes and interventions to answer some crucial questions.
Like what?
Like, were the nursing diagnoses appropriate? Did the patient meet the expected outcomes within the specified time frame? Should the interventions be continued, revised, or discontinued? And have any new problems evolved that require starting the whole nursing process over again?
And the documentation of this phase needs to be objective and concise, directly referencing the goals.
Absolutely. The documented outcomes must be objective measures of the patient's response. The plan of nursing care. You see an example in Chart 1 to 5 for a post-surgical patient is a living document. It has to be continually updated based on this evaluation. If the patient achieved the goal for pain management, that intervention is discontinued. If they fail to meet the goal for ambulation, the interventions must be revised, maybe by consulting physical therapy or revising medication timing.
To tie all of this together, modern professional practice often uses integrated frameworks, like the NCSBN Clinical Judgment Measurement Model, which synthesizes the nursing process with continuous critical thinking.
And this model, which is Figure 1 to 5, provides a really robust framework for measuring and executing clinical decision-making. It's an iterative, cyclical process. It begins with recognizing cues, so identifying relevant data points like abnormal vital signs.
Then comes the vital cognitive jump to analyzing cues. What's the difference there?
Recognizing cues is noting that the blood pressure is low. That's the fact. Analyzing cues is the interpretation of that fact in the context of the patient's history. So the patient had a recent GI bleed, which means a low blood pressure cue now analyzes as a potential sign of hypovolemia.
I see.
This analysis then leads to prioritizing hypotheses. What's the most likely problem and why? Then, generating solutions. What interventions could I do? Taking action, performing the intervention. And finally, evaluating outcomes. Did the intervention work? And all of these layers are constantly influenced by the patient's individual and environmental factors.
As nurses assume greater professional responsibility, they inevitably encounter ethical dilemmas. Having a moral framework is no longer optional, it's mandated.
It is. And we have to start with the fundamental distinction between ethics and morality. Ethics is the formal, systematic study we use to understand, analyze, and evaluate decisions about matters of right and wrong. Morality includes the specific beliefs or actions that individuals hold. So, nurses use the systematic structure of ethics to resolve conflicts that arise from personal moral beliefs.
Let's review the two classic ethical theories that nurses use to justify their actions.
The first is the teleologic theory, which is often known as utilitarianism. This theory focuses entirely on the consequences of actions. The morally correct action is the one that results in the greatest good for the greatest number. The end justifies the means.
And the second theory, which emphasizes duty.
That's the deontologic or formalist theory. Deontology argues that ethical standards or principles exist independently of the consequences. So a nurse acts based on a relevant principle or duty like, always tell the truth, regardless of what the outcome might be.
The challenge, then, is when these two theories conflict. How does a nurse reconcile duty with consequences?
Okay, consider a high-stakes scenario, like triage during a mass casualty event. A strict utilitarian or teleologic approach would dictate prioritizing the greatest number of salvageable lives. You might have to deny immediate care to a severely injured patient who requires vast resources but has a low chance of survival.
But a deontologic approach would say you have a duty to every patient.
A pure deontology approach would argue the nurse has a duty to treat every patient equally, regardless of potential outcomes. Nurses often have to find a systematic way to blend these principles to meet both their professional and societal duties.
And to navigate these conflicts, nurses rely on specific ethical principles, which are detailed in Chart 1-7.
These principles validate moral claims. Autonomy is paramount. The patient's right to self-determination. This means they have to receive adequate and accurate information to make choices free from external coercion. Beneficence is the duty to benefit others and take positive steps to prevent harm, while non-maleficence is the foundational duty to not inflict harm.
Can you explain the principle of double effect? It seems to come up frequently in complex medical decisions.
The principle of double effect addresses actions that might morally justify producing both good and evil effects. This is only justified if 4 stringent criteria are met. The action itself is good or neutral. The agent, so the nurse, intends the good, not the evil effect. The good effect isn't achieved by means of the evil effect. And there's a favorable balance of good over evil.
And this is vital in palliative care.
Absolutely. And finally, there's distributive justice, which requires that benefits and burdens, like resources, be distributed equitably and fairly, without bias related to age, gender, or socioeconomic status.
It's also important to recognize that not every moral issue is a clear dilemma. The source actually distinguishes several types of moral situations that nurses face.
It does. A moral dilemma is that classic conflict. 2 or more equally plausible ethical principles are in direct conflict, and you have to choose between the lesser of 2 evils. A moral problem also has competing claims, but one principle is clearly dominant or superior. Moral uncertainty is where the provider feels strongly that something is wrong, but they can't define the situation or identify which principles apply.
And then there's the highly relatable concept for any working nurse, moral distress.
Moral distress is an internal, crushing response. It happens when the provider knows the correct ethical action to take, but is blocked from acting on that knowledge by external or institutional constraints.
Things like power hierarchies, lack of resources, or restrictive policies.
Exactly.
And research mentioned in the sources reveals the significant impact of this distress.
Yes, studies on moral distress in critical care nurses found it was negatively associated with personal empowerment and a positive ethical climate. But there was a surprising finding.
What was that?
That access to palliative care services was correlated with greater reported moral distress.
That seems counterintuitive.
It does. It doesn't mean palliative care is bad. It suggests that the necessary collaboration between critical care staff and palliative care teams might be strained, or that the moral conflict around end-of-life care is just exacerbated by the need for complex interprofessional negotiation.
Let's discuss some common ethical issues nurses have to navigate daily, starting with the constant mandate of confidentiality.
Confidentiality is mandated by HIPAA and is tied directly to the principle of autonomy and respect. It requires protecting all PHI. And we really cannot stress enough that using non-certified family members as interpreters violates confidentiality rights because that information isn't protected by the required professional standards and agreements. It risks the patient's autonomy and their well-being.
The use of restraints, physical or pharmacologic, is also a major source of ethical tension.
Restraints are a direct limitation of a person's autonomy and human dignity. They must be used only when there is no other viable option to protect the patient or others from immediate harm. Any use requires vigilant monitoring, staff education, and strict adherence to ANA and Joint Commission standards. The ethical calculus is weighing the duty of non-maleficence, so preventing injury, against the violation of autonomy and dignity.
Next, let's discuss truth-telling, or veracity, particularly when a family or a physician wants to withhold a difficult diagnosis from the patient.
This puts the nurse in a direct ethical bind, because veracity is based on the patient's right to autonomy. The nurse must avoid lying under all circumstances.
So what are the strategies?
Strategies involve providing all the necessary information related to nursing procedures, advocating tirelessly for the patient's right to information with the family and the provider, and, if necessary, seeking guidance from the Institutional Ethics Committee to ensure the patient's autonomous rights are respected, even if the news is distressing. Compassionate disclosure is paramount.
What about the nurse's right to refuse care based on personal values?
The ANA Code of Ethics is pretty clear on this. The nurse has an ethical obligation to provide patient-centered care to all patients, regardless of their socioeconomic status, sexual orientation, ethnicity, proximity to death, or the nurse's personal values.
But there are some exceptions.
Accommodations can sometimes be made for non-emergency or elective procedures, like abortions. But in an emergency or in basic medical surgical care, the professional obligation to the patient is primary.
Finally, let's talk about end-of-life issues, which require highly skilled ethical navigation.
In end-of-life care, the focus shifts to palliative care, managing pain and alleviating suffering. The nurse's role is advocacy and facilitating the patient's self-determination regarding treatment.
But the nurse cannot act to end a life.
It is crucial for the nurse to understand the moral difference between active euthanasia, which the ANA Code of Ethics explicitly forbids. Nurses may not act with the sole intent to end life in aggressive pain management. This falls under that principle of double effect.
Can you walk through that again?
If a nurse administers a high dose of morphine to alleviate pain, that's the good intent. And this treatment secondarily and unintentionally hastens death. The evil effect? The action is morally justified because the intent was beneficence, alleviating suffering, and all four criteria of double effect were met.
Because these dilemmas are so frequent, we need systems of preventive ethics steps taken before a crisis occurs, like advanced directives.
The Patient Self-Determination Act encourages preparing advanced directives, and we have to distinguish between them. A living will specifies a patient's wishes regarding life-sustaining treatment, often limited to terminal conditions. A healthcare representative, or proxy, is designated to make decisions on the patient's behalf if they become incapacitated.
And for emergency situations outside the hospital, there's the POLESTI.
The POLS physician orders for life-sustaining treatment is crucial. Standard directives are often limited to the hospital setting. The POLEST is a legally endorsed, bright-colored form in many states that lets EMS personnel rapidly determine a patient's wishes about CPR, intubation, or other interventions outside the hospital, ensuring their autonomy is respected in an emergency.
If a complex dilemma comes up that the interprofessional team can't resolve, they turn to the Institutional Ethics Committee.
And these are vital, multidisciplinary teams. They serve as resources for policy development, education, and consultation on ethical conflicts. Nurses are strongly encouraged to participate in these committees to make sure the nursing perspective is represented in policymaking.
And the ultimate goal is the systematic ethical analysis process, which mirrors the nursing process itself, as shown in Chart 110.
This systematic analysis ensures integrity and justification. It starts with assessment. Identify the moral issues, check relevant institutional policies, and list all the people affected. Then, planning. Collect factual information, distinguish facts from values, and confirm the patient's capacity to make decisions. Next is implementation. List all the alternatives, compare them using those utilitarian or deontologic frameworks, and select and justify the most ethical course of action.
And the final self-reflective step is evaluation.
Evaluation involves deciding the best moral action, giving clear ethical reasons for that decision, and critically actively addressing and documenting any biases or external constraints that might hinder the decision. This rigorous process ensures that complex ethical decisions aren't made on impulse, but are supported by professional integrity and principle.
So if we synthesize everything we've covered today, what's the big picture?
The message is clear. Effective professional nursing practice is fundamentally the synthesis of core professional definitions, the application of mandated quality controls, EBP and QSEN, the continuous exercise of critical thinking and metacognition, the execution of the systematic nursing process, and navigating care delivery within a clearly defined ethical and legal framework. This comprehensive structure is what allows a nurse to move seamlessly from raw observation to ethical, patient-centered action.
That is the essential framework. And since the process of critical thinking requires actively detaching personal bias, what we termed bracketing, here's a final thought for you, the listener.
Okay.
Reflect on a recent clinical situation where you felt intense moral uncertainty or distress. Maybe you knew the correct action but felt institutional constraints were blocking you. I challenge you to apply those systematic ethical analysis steps: assessment, planning, implementation, and evaluation retrospectively. Can you articulate the competing ethical claims, identify the constraints that blocked you, and justify an ideal decision based purely on the principles of autonomy, beneficence, and non-maleficence?
Applying these frameworks after the fact is really the key to accelerating your clinical judgment moving forward.
Thank you for joining us for this deep dive into the fundamentals of professional nursing. We hope this has given you a solid foundation for your practice.
Be well and keep learning.